Stay tuned at the end of this episode for a special treat by Stephen Lachlan.
Hello and welcome to Death is My Life podcast. I'm your host, Jolene. Today I'm going to be talking to you from a hospice nurse perspective about the final days. Okay, so we typically call it imminence or end of life, and everybody always, wants a timeline. So while every death process and journey is unique, there are some similarities that we see sometimes. So I'm going to go over those and just know death does what it wants. But in the final weeks before death, we can see things like increased weakness with falls. Most likely that's been happening already, but it'll get more profound at this point until the point where the person becomes bedbound and really unable to move themselves at all. So management for this is we just keep them safe. You increase your supervision, and then when the time comes, you perform bedbound cares. So bedbound cares, you still need to protect this people's skin because, like I said, every death journey is different. And while this is typical of a few weeks out, that doesn't always mean it is. So we want to still prevent any skin breakdown. So we do this by keeping the people clean, wearing briefs and placing pads under them and rolling them side to side to change them as needed, keeping wrinkles out of the bed. Those are big irritants. Keeping like pillow between the legs if the knees or ankles are touching at all, because that'll help reduce, the bone on bone from one knee to the next pressure. Also, floating the heels. So we put pillows like under the calf so that the heels are not pressed against the bed. Any lack of circulation for just, a few hours can cause skin breakdown. So we really need to be doing these little micro movements every 2 hours at the very least to try to prevent the skin breakdown. We also want to do oral care. So imagine how you would feel if you weren't able to brush your own teeth or, take a sip of water, anything like that. So we have, little kind of like a lollipop, but it's a sponge on the end of a stick, and you can dip it in water and just go around the person's inner mouth and lips if they allow you. Sometimes they clench down and it's more trouble than it is worth, and they're kind of telling you no. So then don't do that. Don't get bit. Never put your fingers inside their mouth. Sometimes it's just a reflex that might happen. In the final weeks, we will likely see decreased food and water intake by mouth. They might ask for something, tell you they're craving it. You're going to make the meal all excited that they want to eat, and they'll take a bite and say that they're done. And that's okay. We never force food. The risk of aspirating into their lungs, is much more significant than the need for calories at this stage. So if they want something and you feel like they're generally safe to eat a bite, then go ahead and provide it for them. Make sure that their head is elevated if they're bedbound, and don't expect them to eat a lot. Meals are for comfort. So if they want something, give it. If not, then don't worry about it. At this point, we generally reduce the medications to those only needed for comfort, and they're usually given crushed, either in a little bit of applesauce or pudding or ice cream, or in just a little bit of water. We may see decreased output, less bowels, and less urines going through, but not always. sometimes people, I feel like, shed a lot of water in their final days. So I wouldn't say that's necessarily a telltale, but it's possible. And then, so hallucinations. This is a interesting one because it's very common for people in their final weeks to report that they're seeing people who have passed on, old family members, their spouse, even their old family dog. And this is so common. It's like, I just call it their welcome party. I just think it's too common to even be considered a hallucination, but for nursing, we have to chart that. Sometimes I am feeling sassy and I just chart seeing people that I do not see. Sorry, boss. I had a family member. So a lot of people, ask, how do we deal with that? And I don't think it's a big issue. If they're comforted by that presence, then there's no need to intervene. Just, okay, you see grandma. Wonderful. Unless they're distressed by it. If it's scary, then you want to tell your team and get some help for that person if they're fearful hallucinations or anything that's causing them distress. Generally, it's not. Generally, they're just seeing people and almost feeling comforted by the presence, is what I have experienced. But I did have a family member one time. I was talking to her about, how's the patient doing? And she said, oh, he's fine. But, a goat got in the house. And so I just had to get on the floor and wrangle that goat and gone back outside. And that is a good family member. So she did what she needed to do to make the family member feel like he wasn't losing his mind. There was not really a goat in the house, but the patient saw a goat in the house. So the spouse got down and wrangled him. And that's just a great story. I think I love Nurse John if you don't watch him. And he's so funny. He does have a video of handling people in the room that we don't see. And it's hilarious. Okay. So then another sign that usually we see like a few weeks out is terminal agitation. Well, maybe within the week, but terminal agitation. So this is like a sudden burst of energy, and the patient is like awake and alert, and they may even get up and be walking around and doing stuff that seems really, it doesn't make sense to us. It seems like they are maybe sleepwalking or something. It can be very difficult to manage, very difficult for families to witness because it's so out of the ordinary. And depending on the level of agitation and the physical ability to function, it can be even harder to manage. If the person is, willing to take an oral medication, then we want to obviously try that first. And there's multiple different things we try. Lorazepam is a benzodiazepine. That's one of them that works pretty quickly and can help settle people down. And some of the diseases that we see, it can make things worse. So we have alternatives, and honestly, that goes with any medication. The hospice providers are fantastic at comparing medications to diagnoses. Haloperidol is another one. It's actually an antipsychotic, but it's given in such a small dose that's like a fifth of the smallest dose that you'll ever see a psych patient on. And it's a tiny, tiny amount. It takes a little bit longer to work, but it lasts longer and it's really effective in somebody who can't or doesn't respond to lorazepam. However, sometimes the oral medication doesn't work, or the person is not willing to take them because they're so agitated and they honestly like don't know what's going on. So some hospices will offer an injection if it gets very, very bad. And I unfortunately had to do that one time, and I hate giving those because they're intramuscular, and these are literally dying patients who generally don't have a lot of extra muscle. So it's physically uncomfortable. And, in this case, the poor guy who was like running around the house, the wife was scared he was going to go outside and get hit by a car or something. So we had to, she had to distract him while I gave him his injection. And then he just looked at me and said, "You injected me with alien blood." And it felt like that. It felt very invasive, and I don't like that. And fortunately, he did calm down and it worked. It was effective. It was what he needed. The wife was very grateful because she could not have dealt with that situation. So yeah, terminal agitation is a really, really tough one. And that is not a typical thing that we see in everybody. So some of these things are like really common. This is something that happens. Don't be fearful of it. Don't sit on the edge of your bed waiting for it to happen. Just know that's a possibility. Okay. So at this point, when people are very close within weeks, they are most likely unable to. Sorry, I did it again. I hope that you didn't hear that. They're most likely unable to report if they're having distressing symptoms like pain. So at this point, we start looking for signs of pain, anxiety, anything like looking tense, fists clenched up, facial grimacing, furrowed brow, groaning, restlessness in bed, labored breathing. And your hospice team would teach you all these things in advance to look for. So if you see any of these signs, like your loved one is probably not comfortable and we're going to want to intervene. And sometimes it's as simple as repositioning, or they need a brief change, or cold pack on their head. It's really hard to generalize that, but you have to take the whole situation into account, right? So a typical comfort pack included in hospice, I know personally every hospice does this a little bit differently, but generally has the same class of medications. So you'll get an opioid for pain, and that's usually in a liquid form or a little pill that you would crush essentially and give with a little tiny bit of water if the patient's not swallowing. You get a benzodiazepine, like I was talking about, lorazepam, that can be for shortness of breath, anxiety, nausea. Oh, and back to the opioids, so like morphine or oxycodone, right? They actually can help if somebody's having shortness of breath too. So pain and shortness of breath can both be affected by the opioids. Ondansetron is a popular one for nausea that just dissolves under the tongue when you can't swallow. So that's really helpful. Bowel care is very important because some of that agitation can actually be caused by constipation. It's weird, but my loved one hasn't eaten in 3 days, but they still have stuff in their body to come out. So usually you'll get a Senna, which is a tiny little brown pill that you'll get. Okay, and then so when we get to like a few days, when we call it that the patient's actually imminent and nursing care bumps up in frequency, you should be, seeing a hospice team member every day. That's our policy. I don't know other hospices, but I would imagine it's the same for that because the patient is so close to death. When they have like days left, there will be nothing by mouth. You're not going to give any scheduled medication unless it's a comfort medication only, like we were talking about. So the liquid morphine or pill crushed up in a tiny bit of water. And these medications, we don't care if they swallow because our whole mouth is made up of mucous membranes. And so these medications absorb into the mucous membranes. And they don't need to swallow, and they are not likely going to swallow at this point. The patient at this point is likely to be non-responsive. So what this means is that they appear asleep and they stay that way even while you're doing your changes. And if they, somebody walks in the room and says their name, they're not likely to respond at all. And when you're doing your bedbound cares, if you're brief changing, they're most of the time appearing asleep. They may grumble, but it's still considered non-responsive. If their eyes are open, they might just have eyes open, but they won't track, so they won't follow you with their eyes. And they remain in this state. They don't necessarily come out. It's general. I've seen everything, but when they're non-responsive in this final stage, once they've gotten to that point, they're very not likely to wake up again. The skin will have a very pale appearance. A lot of the times, hands and feet might have a bluish tint because our circulation is, as we die, like our body shoots all the blood to the most vital organs. So our extremities are the first thing to go. So, like nail beds might have a little bluish tint. You might see like a purple marbling kind of look around the legs, especially, but it can be anywhere. That is typical for the last few days. And breathing. So we can have different breathing patterns that we see. One of them includes apnea. So if you see a breath and then several seconds go by with no breath, and then 2, 3 breaths, and then 5 seconds with no breath. Like those periods will get longer and more frequent until there's just no breathing, typically. We might see a rapid shallow breathing. It doesn't necessarily look agonized, but it's just like that. Or the opposite, where we see the slow, deep breaths, like a fish out of water. That, I mean, I do kind of feel like they look distressing, but at that point, it's kind of pretty close to the end, and there's not a whole lot you can do for that. And I don't know if it is distressing or not, but it's a breathing pattern that's indicative of end of life. Terminal secretions used to be called the death rattle. We don't like that because that's pretty ominous, but respiratory secretions might be heard or even seen. Generally, they're in the back of the throat. So things like suction to try to get them out is not really appropriate. It would just gag the person and you can't really reach it. There are medications for the secretions that we could give. Again, we would crush it up in a little tiny bit of water and let it absorb through the mucous membranes for the secretions. And or there's like a patch that can go back here, so called polyamine patch. There's a couple different things I've seen for the secretions. And let's see. Oh, another thing you can do if you're worried about the secretions is keep the person's bed elevated. So like in a reclined position, not flat on their back. That just may help the drainage. They're not able to cough it up at this point. If you can't elevate their head to bed or they're not comfortable or whatever reason, have them on their side. Then it can come out, have a towel on the bed underneath their mouth just in case it does come out. It's uncomfortable, I think, more for the family than the patients, in my experience. So at this point, we are 100% relying on caregivers to monitor for signs of pain, anxiety, any any sign of distress, and intervene appropriately, whether that's medication or repositioning, contacting your nurse, whatever it be. That's now the caregiver's job because the patient has no ability to speak for themselves. Okay, and then the patient passes away and we get to the post-mortem stage of life, and that is death. So there's no breaths, no heartbeat for 1 full minute. The breaths is our bodies kind of release gas, and our minds, in the state of this heightened emotional state, we might think we see breathing, or we might see breathing as the gases release. So when the nurse comes, we check the heartbeat for a full minute to make sure that there's no heartbeat and that the person has actually passed. The skin will look gray and waxy. Not all the time. Sometimes that takes a little while to kick in, but there's no muscle tone left whatsoever. So the eyelids may be open, the jaw may be slack, the tissues may kind of pool onto the surface of the pillow or the bed. And it is normal to release body fluids. Everybody's in a brief at this stage usually anyway. So sometimes your team will help clean up, funeral home will help clean up, but that is a totally normal thing to happen. And and that's that. So the glamorous end of life. Do you have any questions? I hope I went over that in a way that it makes sense to everybody.
Every day that passes, I learn a little more. There's always something I've never seen before. It's effortless attention, I'm dreaming all the time. And everything around me filters through my mind. Somewhere in my memory, I got impressions of every moment since I came to be. I was born to fill up the space I bring the story back with me to the ground, moving under my feet. The places I travel, the people that I meet, the days with the rhythm and beat, the nights I unravel, the puzzle I complete. I'm simple animation like any other man. In the hourglass, another grain of sand. Soaking up sensation and chilling through the years, and always fearing the end is getting near. I dream of immortality as I am now, though I know it isn't meant to be. But I'll be here forever as part of everything, and it will grow because of me. I'm the ground moving under my feet. The places I travel, the people that I meet, the days with their rhythm and beat, the nights I